Thank you for your hard work today in anesthetizing a challenging patient for a complex surgery. Grazie per il duro lavoro svolto oggi nell'anestetizzare un paziente difficile per un intervento chirurgico complesso. आज एक जटिल सर्जरी के लिए एक चुनौतीपूर्ण मरीज को बेहोश करने में आपके अथक परिश्रम के लिए धन्यवाद. I know how tough those days can be. And today, we're going to tackle a topic that really tests us as clinicians, a high-stakes, low-frequency event that demands our absolute best, cardiac tamponade.
Welcome! In this session, we are going to go on a clinical deep dive into the anesthetic management of cardiac tamponade. You know, the goal here is to get way beyond the textbook answers and really dig into the nuanced, high-pressure decisions we have to make at the bedside. We'll cover everything from the fundamental why of the pathophysiology all the way to the treacherous landscape of post-op care.
So here's our roadmap. First, we're going to break down the vicious cycle of tamponade, really get to the heart of why these patients collapse. Then, we'll shift gears to diagnosis, looking at both the classic signs we all know and the dangerously atypical ones that can trip us up. After that, we dive into our world, anesthesia, and navigating the crisis. Next, we'll talk about the fix, the interventions that restore cardiac space. And finally, we'll wrap up with the really tricky stuff, special cases like post-op tamponade, where the rules don't always apply.
All right, let's jump right into section 1. You know, understanding the core pathophysiology, it isn't just some academic exercise. It is the absolute foundation for every single clinical decision we're going to make when that patient is circling the drain. Every choice, from the fluids we give to the drugs we push, stems from these first principles. First off, let's get our definition straight. Cardiac tamponade is not just about having some fluid around the heart. It's a dynamic state, a process of circulatory failure. The key concept here is extrinsic compression. The heart is literally being squeezed from the outside, and because of that, it simply cannot fill with blood. It's a space problem, plain and simple.
So what determines when a patient crashes? It all comes down to this critical pressure-volume relationship. It's not just how much fluid, but how fast it accumulates. Think about acute trauma. The pericardium is tough and fibrous. It can't stretch quickly. So as little as 150 or 200 milliliters of blood can cause a catastrophic, almost vertical spike in pressure. The patient collapses. Now contrast that with a chronic process, like a cancer-related effusion that builds over weeks. The pericardium has had time to stretch, to remodel. It can accommodate huge volumes, sometimes up to 2 liters, before it finally hits that same breaking point.
So how does this pressure lead to a full-blown collapse? Well, it's a predictable and vicious cascade of events. First, the pressure outside the heart rises until it's higher than the pressure inside the heart during filling. That means the ventricles literally can't expand to accept blood. Their diastolic compliance is shot. This leads to a key hemodynamic sign, pressure equilibration. Your CVP, your PA diastolic, your wedge pressure, they all start to look the same. This kills the pressure gradient that drives blood into the heart, and the result? A catastrophic preload crash. The ventricles are empty, and an empty heart has nothing to pump, which leads to the final step, total circulatory collapse.
And this right here, this is probably the single most important concept to grasp about this entire condition. The collapse in cardiac output is not a pump problem. The heart muscle itself is usually working just fine, at least initially. This is a filling problem, not a squeezing problem. It is the ultimate form of diastolic failure. And that means every single thing we do has to be aimed at fixing that filling problem. Just cranking up the inotropes won't work because you can't squeeze what isn't there.
Now, to make things even worse, you've got this phenomenon called ventricular interdependence, which gets dangerously exaggerated in tamponade. Normally, when we breathe in, a little more blood returns to the right ventricle, and the septum between the ventricles bulges just slightly to the left. No big deal. But in tamponade, the heart is trapped in a fixed-volume, high-pressure box, so when the RV fills on inspiration, it has nowhere to expand except into the left ventricle. The septum bows sharply to the left, crushing the LV and preventing it from filling. This is the direct cause of that classic sign, pulsus paradoxus.
Faced with this disaster, the body mounts a desperate, all-out defense, driven entirely by a massive sympathetic surge. The heart rate skyrockets to try to keep cardiac output up as stroke volume plummets. The body clamps down everywhere, jacking up the SVR to try and perfuse the brain and heart. But we have to remember, these are fragile temporary measures. The patient is living on a razor's edge, completely dependent on their own catecholamines. Our number one job as anesthesiologists is to do nothing that undermines these defenses.
Okay, let's move on. Now that we understand the why, let's talk about the how. How do we actually recognize this thing at the bedside? Because in the chaos of the OR or the ICU, this diagnosis can be a real chameleon. It's all about building a high index of suspicion. Of course, we all learned Beck's triad in medical school: hypotension, JVD, and muffled heart sounds. It's clean, it's classic, and if you see it in the ER in a trauma patient, you should absolutely be thinking tamponade.
But here's the million-dollar question for us, right? What if that triad isn't there, or what if it's misleading? This is the reality we face every day, especially with our post-op cardiac patients who are intubated, sedated, and on a ventilator. Relying on Beck's triad in that setting, well, that's a recipe for disaster.
A much more useful sign, at least in a spontaneously breathing patient, is pulsus paradoxus. It's that drop in systolic blood pressure of more than 10 millimeters of mercury during inspiration. And as we just talked about, it is the direct physical sign of that exaggerated ventricular interdependence. It's a huge clue that something is seriously wrong with cardiac filling.
But now, let's flip everything on its head, because this is what we'll see in our ventilated patients. It's called reversed pulsus paradoxus. With positive pressure ventilation, a mechanical breath actually squeezes blood out of the lungs and into the left heart, which momentarily increases LV preload and systolic pressure. At the same time, that positive pressure is impeding venous return to the right heart. And a few beats later, during expiration, the effect of that empty right heart shows up as a drop in LV filling and a fall in arterial pressure. So on your art line, you'll see the pressure drop on expiration. It's the exact opposite of the classic sign, and if you're not looking for it, you will miss it.
Another huge drop is staring at the CVP number. Sure, in classic tamponade, the CVP is high, but in the post-op setting, it's notoriously unreliable. The patient could be hypovolemic, masking the rise. More importantly, they could have a loculated clot squishing the back of the heart that doesn't affect the CVP at all. And of course, a dozen other things can make the CVP high. So here's the bottom line. Never, ever rule out tamponade just because the CVP is normal.
This is exactly why echocardiography is the gold standard. It's not just nice to have, it's essential. These are the expert-level signs we need to be looking for. The most specific findings are seeing those low-pressure right-sided chambers get crushed during diastole, the RV free wall collapsing early, the RA collapsing late. This happens the moment the pressure outside the chamber is higher than the pressure inside. Doppler findings, like big respiratory swings and flow across the mitral valve, and that classic swinging heart, these are all definitive clues.
So when your post-op patient is crashing, this table is your mental checklist. How do you tell tamponade from other disasters? In tamponade, all the filling pressures equalize. In LV failure, the wedge is going to be way higher than the CVP. In a massive PE, the CVP is going to be sky high. But again, echo tells the story. Tamponade shows effusion and chamber collapse. LV failure shows a poorly squeezing heart. A PE shows a massively dilated, struggling RV. The context and the echo together give you the answer.
Okay, let's get to it. Section 3. This is our turf. This is our command guide for navigating this crisis and keeping the patient alive until the problem can be fixed. This is where our specific skills can literally be the difference between life and death.
Our choice of drugs here is absolutely critical. The wrong one can be lethal. Ketamine is often the best choice for induction because it preserves that vital sympathetic drive. Etomidate is also an excellent hemodynamically stable option. Now, look at propofol. With its 1-2 punch of myocardial depression and vasodilation, it can be the final straw that causes a complete cardiovascular collapse. It should be used with extreme caution, if at all. For maintenance, a little bit of volatile and a good dose of opioid is usually the way to go. Anything to avoid dropping that SVR.
I honestly cannot say this enough. The induction of general anesthesia is the single most dangerous moment. You are about to take away every single compensatory mechanism that is keeping that patient alive. So before you even think about pushing that induction drug, the surgeon absolutely must be scrubbed, gowned, gloved, with the patient prepped and draped, and a scalpel in their hand ready to cut. This is a non-negotiable team huddle. Our entire plan boils down to these 3 core principles. Think of it as our tamponade triangle. First, maintain preload aggressively. You're in a battle of pressures, inside the heart versus outside. You need to win. That means pouring in volume to get that CVP up, maybe even to 25 or 30. Second,
preserve that sympathetic tone. Choose your drugs wisely and be ready with pressors and inotropes. And third, and this is so critical, keep the patient breathing on their own for as long as you possibly can. That switch to positive pressure ventilation before the chest is open can be the thing that causes a complete arrest.
And just as important as what to do is what not to do. Think of this as a list of landmines to avoid. Any kind of spinal or epidural is absolutely out. The sympathetic blockade would be catastrophic. High-dose volatile agents will kill their SVR. High PEEP will choke off what little venous return is left, and using afterload reducers, well, that's just a recipe for profound hypotension in a patient who is desperately preload dependent.
All right, section 4. Let's talk about the fix. This is about the definitive treatment, giving the heart its space back, and being ready for the wild hemodynamic swings that happen the second that pressure is released. It's all about restoring that space.
The fix, of course, is drainage. For a simple fluid effusion, a needle pericardiocentesis might do the trick, but for our post-op patients with clotted blood, a surgical subxiphoid window is usually necessary. The huge advantage here is that the surgeon can often start this under local anesthesia and sedation, getting some of the pressure off before we have to commit to general anesthesia. And for major trauma or a surgical bleed, a full sternotomy is the only way to go.
The second the surgeon gets into that pericardial space and releases the pressure, it is one of the most dramatic moments you will ever see. The heart is suddenly free. You should expect an immediate, sharp rise in cardiac output and blood pressure. Your job is to be ready for it. Be prepared to shut off all your pressors and inotropes. In fact, the patient might swing to being profoundly hypertensive from all those circulating catecholamines. You need to be ready with vasodilators. Success isn't just seeing fluid come out, it's seeing those hemodynamics normalize instantly.
And now for our last section, where things get really, really tricky. Let's talk about the special cases, especially the post-cardiac surgery patient, where tamponade just doesn't follow the rules. This is where clinical experience and suspicion really come into play. Diagnosing tamponade after cardiac surgery is incredibly difficult because it's often a regional problem. You can have a collection of clot just sitting behind the left atrium, compressing it, while the right side looks fine. This means that classic sign of pressure equilibrization is often absent in up to a third of cases. The open pericardium means the pressure isn't transmitted globally, and as we've said, Beck's triad and pulses are useless here. This is why your brain is your best diagnostic tool. Any unexplained hypotension or failure to wean from pressors in a post-op cardiac patient must make you think, could this be a loculated tamponade?
The timing can also give you a huge clue. If it happens early, within the first week, it's almost certainly surgical bleeding, and it's going to be clotted. If it happens late after a week, it's more likely to be an inflammatory process, like post-pericardiotomy syndrome, and the fluid will be serous. That difference dictates the best approach for drainage.
And we should always have the humility to remember the iatrogenic causes. This can be a rare but devastating complication of procedures we do every day, like placing central lines or pacemaker wires. We have to maintain that high index of suspicion, not just in post-op patients, but in any patient with central access who suddenly becomes unstable.
Really, this says it all, especially for these complex cases. You cannot afford to wait for the textbook signs to appear, because in the post-op patient, they probably won't. The most powerful tool you have is that voice in the back of your head saying, "This doesn't feel right." If the patient is unstable, you have to think tamponade and get the echo probe on their chest.
So I'll leave you with this final thought, a question to take back to your practice. Your post-op cardiac patient is hypotensive. Is your first instinct to reach for the vasopressor or to reach for the ultrasound probe? For any unexplained instability, the answer has to be the ultrasound probe first. It will give you the diagnosis and guide you to the right therapy instead of just treating a number. Thank you.